the topics that are in the circulatory chapter that we'll be talking about. I kind of split them up based on kind of like the category. This isn't necessarily the order that the book puts them in, but all the conditions that have to do with the heart itself, I put here. Things that just have to do specifically with the blood vessels, the blood, and the lymph. So, like I said, it's not necessarily the same order. Like, for example, the book starts with coronary artery disease, whereas we'll be starting with myocardial infarction. So it might not be in the same order, but I did that to try to help you realize like what conditions go under what category. Okay. All right, so we're going to talk about diagnostic tests in the beginning. So probably many of you are aware of blood pressure, right? You use a sphygmomanometer. That's actually the fancy name for a blood pressure cuff. It's just easier to say blood pressure cuff. This is what measures how much pressure is in your vessels at any given time. Normal reading is 120/80. Okay, so anything above that is considered hypertension, right? It's not technically considered hypertension until we're above 140, the top number, and 90 on the bottom number. But we'll get to that when we talk about hypertension. There's also something called ambulatory monitoring. That's just where a patient gets a blood pressure cuff that they take their readings at home. Okay, so like the doctor tells them, hey, like take your blood pressure 3 times a day, first time when you wake up, sometime in the middle of the day, in the evening, whatever, what have you. Because some people have what's called white coat syndrome. Anybody heard of that before? Yeah. White coat syndrome is basically they see a doctor in a white coat and they get nervous and their blood pressure goes up. So every time they come to the doctor, their blood pressure is high, but like normally it's not.
That's a thing.
It's a psychological thing, yeah. So what they do is they do ambulatory monitoring. It's like some people are at the comfort of their own home and they shouldn't feel anxious. They take their own blood pressure, and if those readings are normal, then they'll be like, okay, it's fine. If those readings are still elevated, then they'll give you a diagnosis of hypertension. So that's just what that is. And then there's heart rate. That's just literally how many times your heart is beating in a minute. So you can take this yourself. You just put your fingers on your neck. You feel that carotid artery. You can count. Normal is 60 to 100. Anything below that, is considered abnormal. Anything above that is considered abnormal. Unless obviously you're exercising. This is at rest. Your heart rate will be higher when you're exercising, obviously. Okay, then we have an EKG, which is also sometimes called an ECG, which is basically an electrocardiogram. This is measuring the electrical activity of your heart. Okay, you've probably seen these in I don't know if you work in the medical field or if you've seen them on movies or whatever, where they have these little lines. This is just showing the electrical activity of the heart. You have there's nodes in the heart that release electrical signals that indicate how often your heart should be beating, things of that nature. They also have something called a Holter monitor, which is very similar to like the ambulatory monitoring for blood pressure. It's a little device that you wear on your chest at home so that you can they can get a reading of the electrical conduction system over like a period of days or weeks rather than just like one time in the office, right? Because like you sit down in an office and do this, it might be like a 15-minute thing. And if your heart is not doing anything weird within those 15 minutes, it's going to miss it, right? Whereas if you wear one of these and take it home, over the period of several days, you're more likely to catch stuff. Does that make sense?
One of these?
Oh, is that what you have right now? Oh, cool. What's, do you want to share? Or?
I've just been having some tachycardia issues.
Tachycardia is, anybody know what that means?
Heart rate.
Elevated heart rate, yeah. So that's what a Holter monitor is. They're measuring to see what's going on over how long do you have to wear it?
2 weeks.
2 weeks. Okay, so yeah, that's, can you shower with it? Or do you have to take it off?
No, I have to. The leads are waterproof, but
I know they have some that can, some that can't.
The box itself, yeah.
You have a phone with it?
Huh?
You have a phone with it?
No, it's
Just a little monitor. They all look a little different.
Yeah. Some people have a cell phone with it.
Yeah.
Mine was like actually stuck on me.
Yeah. They have different kinds.
Yeah.
It's 3 lead.
That's like this one. This one has 3. But yeah, it's just measuring over time, so they can catch more things, right? Because it's unlikely they're going to catch something within like 15 minutes unless you're actively having a problem right then,
Yeah.
right?
Every time I go to the ER, if I'm having palpitations or anything, flutter.
And then it behaves as soon as you get there.
When I get there, it's like
Normal, yeah.
Like,
Then they have something called telemetry. This is just where you're on like a continuous EKG, like hooked up to leads and someone's watching you in the hospital. So it's like for the duration of your stay, if you're like a cardiac patient, they'll have you hooked up and someone is, paid to sit in the monitors and watch the electrical activity.
That's what I did for the past 2 years.
You did telemetry? Nice. This is cut off, I'm sorry. It says echocardiogram. Basically what this is, it's kind of like an ultrasound, like when you go in, if you're, for like a baby, like put the probe to look at the features of the baby. It's kind of the same idea. They use that to look at the physical structures of the heart, right? So they can like see, you don't need to know all these things, but this is just kind of an image of what they're seeing. They're seeing the different chambers. They can actually watch the heart beating in real time, so they can see the valves working, the different chambers squeezing, the blood coming out, and various things. So that's really helpful for seeing like if there's an anatomical defect or if there's something wrong with the valves, they can see the heart pumping in real time. All right, they have two different ways of doing an echocardiogram. They have a TTE or a TEE. One is transthoracic, the other one is transesophageal. This just means they're going, so this one up here is transthoracic, okay? It's going through the thoracic cavity, which is just what they call the chest. So they're holding it right above the sternum. Whereas a transesophageal is they're gonna hold the probe like literally down your esophagus, hence esophageal. And the probe gets right under the heart. So it's like a way to see the back side of the heart versus like the front side of the heart. Does that make sense? So this one, yeah, it's very, not super pleasant, but they can see the back side rather than if you went through the chest, you'd see the front side. So it kind of just depends what they're looking for to determine which one they're gonna do. And then also part of an echocardiogram is you can get someone's ejection fraction. Like I said, you can see the blood pumping out of the heart in real time. So an ejection fraction is basically how much blood the heart is able to pump out in one beat, right? The heart is responsible for pumping out blood, right? So they're going to do a measurement of how much blood comes out of the heart within that one beat, and that's that comes in a percentage. Okay, so 55% and up is considered normal. The higher, the better. That just means your heart is stronger because your heart is a muscle, it's a pump, so it should be strong enough to squeeze hard, and the more blood it's able to spurt out in one beat, the stronger your heart is. Does that make sense? So 55% and up, that sounds pretty low, doesn't it? It sounds like half, but that's actually considered normal. All the way up to usually about 75% is usually the top number. There's 100% isn't like the goal. It's 55 to 75 is usually the goal range. Anything below that is your heart is pretty weak and not pumping effectively, okay? All right, sorry, this picture quality is terrible, but it's hard to find pictures that look good when you blow them up. A stress test, this is basically where, if someone's concerned that you have heart issues, you go in for what's called a stress test. You basically walk on a treadmill, they might have you jog or maybe run, depending on how it goes. And then you're hooked up to all these different monitoring. They've got an EKG going, they're taking your blood pressure periodically to see what your heart does when it's under stress, right? That's why it's called a stress test. So like obviously physical activity puts stress on the heart, okay? So this just gives them an idea of how well your heart is able to respond to stress, whether you're at risk for heart attack and things of that nature. All right, then we have what's called you can either called coronary angiography or cardiac angiography. It's kind of both ways is fine. Or you might have heard of a heart cath. It's also called that as well. Basically, they insert a catheter, which is like a flexible little tube, and they usually go into one of those big vessels in the groin or in the wrist, and they kind of weave it up through the blood vessels. They guide it up into the heart, and they insert, you can see here's that little catheter. They insert some contrast dye so that they're able to visualize those vessels, kind of like with the eye with the fluorescein angiography, right? You got that same word there, angiography. And that can show them if there's like a blockage. You can see how there's this plaque here that's blocking off the vessels, so they can see where those blockages are and if they need to do surgery to correct that. You can see that the catheter here is being inserted in the groin. The groin is pretty common because it's a bigger vessel than it is in the wrist there. Any questions so far? Okay. Feel free to stop me. Like I said, we can take our time today. We're not trying to rush.
TDE, is that considered invasive, right?
I mean, probably. Yeah.
Going through.
Well, I mean, because I think about like a nasogastric tube. That's not, people don't get put under for that. So I don't know. I don't know enough about all that.
So invasive is basically you have to be put under.
I mean, I know, because I've done NG tube, just a little bit, like, it goes up their nose and down their esophagus. They're not put under for that, which I feel like I couldn't do that. I'd probably ask to be put under personally, but they wouldn't. I'm not sure, actually, if you get put under
I've
for that or not.
assisted with a bunch of those.
Yeah. I'm not an expert on all, like, because I don't do that line of work. So, I mean, I would assume probably, but I'm not sure. And you don't have to know either. For that.
I just feel like if it goes in the body, it's invasive.
Yeah. I mean, technically, if it goes inside you, but. Or then we have various simple blood tests. You know, you go and they just take a blood sample and they can do all sorts of, magical wizardry to determine what's wrong with you. So there's something called troponins. Basically just know that these are released only when your heart is actively being damaged. Okay, so this is very useful to see if someone's currently having an MI. MI is myocardial infarction, which is the medical term for heart attack. Okay, so when your heart is actively like dying, right, it will release these enzymes, and one of them is called troponins. So if you have positive troponins, that means your heart is in distress. Right? If you have no troponins, that's good. You don't want troponins. Okay. Same thing with the CKMB. That's also kind of measuring the same thing, the same idea. Your heart is being damaged. It releases those enzymes. And we could get super in depth with like what they specifically measure and all that, but you guys, for the sake of what you guys need to know, it doesn't matter. Just know that it's measuring heart distress. Okay. BNP. This is what the heart releases when it's struggling to pump. So we talked about ejection fraction, right? Or the heart is how much blood it's able to pump out in one beat, right? If it's struggling to pump, like you have a very low ejection fraction, like maybe 40%, you'll probably also have a positive BNP, right? Because your heart is a muscle, it's a pump, and if it's struggling doing that, you'll have positive BNPs. We'll talk about congestive heart failure in a little bit. That's a type of issue with the issues with pumping of the heart, okay? And we know what lipids are. Ever heard of those? A lipid panel?
Cholesterol.
Yeah, so this is measuring your cholesterol. There actually is,
Triglycerides.
yeah, all that stuff. Triglycerides, healthy cholesterol and bad cholesterol. There's actually good cholesterol, if you guys didn't know. Not all cholesterol is bad. But this is just measuring all of that, your fat, like she said, triglycerides as well, cholesterol. So this will determine whether or not you need to watch your cholesterol, because cholesterol can build up on the inside of your arteries, like up here. See that plaque and stuff? This can be due to cholesterol buildup, right? So we don't want that. All right, then there is a BMP and CMP. These are basically the same thing, except one just has a few more things. So this one is basic metabolic panel, and this one's a complete metabolic panel. But it's generally they're measuring the same stuff. So what they're looking at is your electrolytes. So like, potassium, sodium, calcium, all those different things. Kidney function, how well your kidneys are working, your liver function, how well that's working, and then also like your blood sugars. So that's kind of what they're looking for. And this just gives kind of a broad picture of what's going on in your body. It doesn't like give a specific diagnosis, like whereas troponins are like, yes, your heart is in distress. This gives like a big picture of what's going on in your body. And then I've talked about CRP and ESR several times. This just measures inflammation. It doesn't tell you where the inflammation is happening or why it's happening. It just tells you whether or not it is happening. Okay, so it's useful, but to a point. And then there's a D-dimer. This will tell you if someone's having a clot. Okay, so we talked about pulmonary embolism in respiratory, where a clot goes to your lungs, right? And you have that feeling of, I can't breathe, that feeling of impending doom and anxiety. A D-dimer is guaranteed going to be ordered to see if there is a positive for a big clot, okay? Any questions about any of these blood tests? Like I said, really all you really need to know is to be able to identify what they're for, right? So if you see a troponin, just know like, okay, they use that to measure heart damage, right? If you see CRP, just know that's to measure inflammation, right? So you don't need to know how it works, what the levels are, what the normal values are, any of that stuff, because you guys aren't trying to be nurses or doctors. You just need to be able to recognize what tests are for to help to know if they support certain diagnoses, right? If someone said, if you're looking at a patient's chart and it says positive elevated D-dimer, you should think, oh, this person probably has a clotting issue. That's all, okay? All right, so we're going to talk about different conditions about the heart itself. First one we're going to talk about is angina. Anybody heard of angina before? What is it?
It's where you're having, chest pain, but it's not, intense.
Yeah, so it's transient, right? Transient meaning it comes and goes. It's kind of intermittent. It's not chronic. It's not quite a heart attack yet, but it's usually a warning sign that you're going to be having one probably eventually. Basically what's happening here is you have this chest pain due to the fact that there's a lack of oxygen getting to your heart itself, okay? And that's usually because you have some blocked arteries, like I showed you up here, like these blocked arteries, so blood and oxygen is having a difficult time getting through, which, especially if you're doing any physical activity, like walking, going to the gym or whatever, where your heart rate increases and your demand increases, people tend to feel the chest pain because their heart isn't able to get the nutrients it needs. So usually the feeling goes away when people sit down, kind of relax and let their heart calm down, right? So if someone does have this angina, this kind of chest pain that comes and goes with activity, this is a warning sign of impending MI or impending myocardial infarction. Okay, we haven't talked about this yet, but a TIA is also a warning sign for stroke. We'll talk about more when we get to neuro, but it's kind of the same idea. So like I said, chest pain shortly after exertion. Who knows what ischemia is? That's one of our terms.
Like a heart attack.
Well,
Mild.
Lack of blood.
yeah, so a heart attack is due to ischemia, right? So ischemia just means a lack of blood flow, which ultimately means a lack of oxygen, right? Because oxygen is carried on the blood, right? Specifically the red blood cells, they are the ones that carry oxygen on the hemoglobin. You know, if you've heard of hemoglobin before, that's what carries oxygen to your body. All right, how we diagnose this, people can do EKG, kind of see the electrical activity of the heart. Stress test, this is really good for people with angina, right? They have you on a treadmill, they give you a little bit of stress on your heart, and they see, oh, are you getting chest pain? What's your blood pressure like? What's your EKG doing, right? So that's really helpful. And then obviously they're going to do a cardiac angiography, which is looking at those blockages to see if there's any narrowing of those arteries or if there's lack of blood flow, okay? Treatment-wise, stop strenuous activity, right? You don't want to have a heart attack, so don't do anything that gives you chest pain. The main medication that they give people is nitroglycerin. Who's heard of nitro before? It's pretty common. They have different forms of it, but the most common one is sublingual. Sub meaning under, like submarine, right? Going under the water. So sub means under, and lingual is your tongue, kind of like linguistics. It's a language using your tongue, right? So you put the tab underneath your tongue and it kind of dissolves immediately and goes straight into your bloodstream. And what that does is it helps to make your vessels go like this. What do we call that when something gets wider? Yeah, so it's not constrict. Constrict is getting closer. It's dilating. So they're specifically acting on the blood vessels. They call it vasodilate. Okay, vasodilator. So that's what nitroglycerin does. Is it causes your blood vessels to widen, and when they're wider, more blood can get through. Right, so that more blood flow can get through to the heart, deliver that oxygen, and it should relieve the chest pain. Prognosis for this: these are acute attacks, right? So it's not angina if the pain does not go away with rest. Now you're just having like a full-blown heart attack, right? So angina is where you have these intermittent episodes with exertion, and the pain goes away when you take nitro or when you stop and give yourself a rest. Okay, so there are these intermittent attacks. The prognosis is progressive in the sense that, like, if you don't get this addressed and you don't get your arteries fixed, it could develop into a heart attack. Okay, does that make sense? And here's a picture of that vasoconstriction and vasodilation. So constriction is closing the vessel off. Vasodilation is opening it up more. That's what nitroglycerin does. All right, since we talked about it, we're going to start with, our next one's going to be myocardial infarction. Okay, so full-blown heart attack. This is when the heart tissue actually starts to die. Okay, so like the heart tissue actually dies from lack of oxygen, right? So it's like angina progressed, essentially. And once the heart tissue dies, you can't get it back, right? Like it's just dead. That's kind of the same idea with a stroke, right? Like parts of the brain, when they die, they don't work anymore. You know, that's why some people with strokes have a hard time with like speaking, or they lose the ability to move on one side of their body, right? Because that part of the brain is just dead. right? So if you have a part of the heart that is dead, you can imagine that the heart doesn't work at the same capacity that it used to, right? Like it can't pump as well, it's going to have problems. And depending on how bad the heart attack was, kind of depends on what your life is going to look like afterwards. So yeah, etiology is not enough oxygen to the heart itself due to occlusion. What's occlusion mean? If something is occluded?
It's,
Blocked, yep. So that's just what we call like a coronary occlusion is a blocked artery, right? Usually due to cholesterol or a plaque or maybe even a clot, resulting in ischemia, which is lack of oxygen, to a portion of the myocardium. And that's what they call the heart muscle itself, is the myocardium. Myo always means muscle in medical terminology, and then cardium is like cardio, right? So the heart muscle itself. So symptoms of this, everyone pretty much knows the symptoms of heart attack. You get that severe sudden chest pain. Sometimes it goes down to that left arm and you have the pain there. You kind of see people in the movies, they clutch their arm and they're like, ah, you know, so it's kind of, those are pretty common. Diagnosis, we talked about those troponins, right? And the CK-MB blood tests. So those lab tests for cardiac enzymes shows if the heart's in distress. We talked about troponins. They can also do EKG. So here's an EKG. Here's a normal one. You can see this one looks different, right, than normal.
ST elevation.
Exactly. This is what they call ST elevation. You don't need to know all that stuff, but I mean, if you're curious, you know, this is called the QRST, as different waves of the part of the EKG. So when this part is elevated up from normal, see that this is the normal level and it's elevated, so the ST is elevated. That usually is very indicative that someone's having a heart attack, okay?
Oh, it's STEMI.
Yeah, so, a STEMI. Not all heart attacks have it, but obviously you're very well aware of all this stuff because you worked in telemetry. Not all heart attacks have this, but a lot of them do. So ST elevation is a big one for diagnosing a heart attack. If someone is having a heart attack, you're going to give them oxygen. So you like put them, you know, on one of those little nasal cannulas, the thing that goes in their nose, and give them extra oxygen. That'll help give them more oxygen to their body. Vasodilators, so like nitroglycerin, for example, to open up those vessels and get more blood flow there. What is a thrombolytic drug? We talked about this, I think, in respiratory.
Blood clot.
So blood clot breaking down, right? So thrombo, meaning thrombocyte, which is the medical term for a platelet, which is what's responsible for the clotting, right? And then lytic means to break down, right? So thrombolytic means to break down a platelet. So if someone is having a heart attack due to a clot, like a clot is blocking one of the arteries, then we can give them a thrombolytic drug to break down that clot. They can also do surgery. Everybody heard of a cabbage before? Cabbage, that's just kind of what they call it because it looks like it says cabbage, C-A-B-G. It's a coronary artery bypass graft. So, oh, I thought I had a picture of it. I think I have a picture of it later on. Basically, if you have an artery that's blocked off, right, rather than, one of the things they can do is just kind of bypass that spot. So they'll take another vessel, like if this is the blood vessel, they'll take a vessel and attach it here and go around the blockage. They create like an exit ramp and like come back into traffic, like, you know, where traffic is blocked. Sometimes people take like an exit ramp to bypass the traffic. It's basically the same idea. They take a blood vessel and surgically attach it and go around the blockage so that they don't have to worry about it as much. There's also something called an angioplasty with a stent, and here's a picture of that. So if like there's a narrowing due to plaque here, they'll stick in like a little, this is what they call a stent, which basically just widens it and opens it up to allow the blood flow to get through. So there's little different things that kind of like determines, you know, what they're gonna do. You just need to know that if someone, you know, be able to recognize like what is an angioplasty and like what diagnoses would it likely be for. Or like, okay, someone needs a stent for clogged arteries. They probably have high cholesterol, or they might have had a heart attack. You know, just general terms, right? You should just be able to have an idea of what an angioplasty is, what a cabbage is, those types of things. Just be able to like have it trigger like, oh, that's probably heart related. That's probably vessel related. Does that make sense? If you see these things on a patient's chart and you have to support a diagnosis, all of these different things, these procedures or history that they've had will help to support a diagnosis. Does that make sense? All right, and then prognosis. the heart attack itself is acute, right? But depending on how bad it is, or if they're able to catch it in time, or how severe it is, it could cause chronic irreparable damage, right? You can catch a heart attack in time, or it can be not that bad, but depending on how much of the muscle is dead will tell you how much problems you're going to have later on. But like I said, any heart muscle that is permanently damaged is irreversible, okay? You're not able to get that function back. Any questions at all on this one? All right, now we're going to talk about hypertension. This is basically just high blood pressure. All right, we know hyper, the root of hyper means too much, and tension is just referring to pressure. So too much pressure, high blood pressure. There are various risk factors involved with someone who develop high blood pressure. So stress is a really big one. People that are constantly under a lot of stress, it puts your body into that fight or flight syndrome. Your body's releasing tons of like adrenaline and cortisol all the time, which constantly just puts your body in like this like anxiety mode, right? Where it's going to raise your blood pressure, and just being in that sustained state for a long time is not good for your blood pressure. Age also, just as we get older, your things just kind of start to hit the fan, right? Our bodies start to get worse. So your vessels actually start to get harder and less elastic as you get older. Kind of just like the skin too. Skin loses its elasticity, so it's not as like supple and nice. It starts to sag, right? So vessels get harder, and when they get harder, the blood pressure goes up. Heredity, so some of it's just genetic. Blood pressure can run in people's families, and it's just not their fault. Smoking is a big one. Smoking, the nicotine hardens the arteries. It makes them less elastic, right? So if your vessels aren't elastic, it's going to be harder for them to dilate, right, to stretch. Think of like a rubber band that's gotten dry rotted. You know, it doesn't stretch anymore. It's just kind of hard and stiff, or like a bathing suit that's lost its stretchy, right? It's kind of the same idea. Obesity also is related to high blood pressure, and a sedentary lifestyle. So sedentary lifestyle just means you're not doing much exercise, okay? The benefit of exercise is it trains your vessels to be able to cope between like having to go from high blood pressure to low blood pressure. Like it's working out your blood vessels, right? So if they're not used to it, they're just gonna start losing, kind of like with age, they start losing their elasticity faster, right? So they're just not being worked out. Symptoms of blood pressure, often people don't realize it, okay? So these symptoms are only like when the blood pressure starts to get bad, right? Generally people with high blood pressure have no idea. It's kind of asymptomatic for a while until it starts to get bad. So that's why it's just important to have your regular checkups and things and check on things, so you might not realize it. But once your blood pressure gets to like a kind of dangerous level, you can start getting really bad headaches. Epistaxis, who remembers what that means? That's from way back. That's nosebleeds. So the pressure gets so bad that like it bursts the tiny little vessels in your nose. You have very, very tiny blood vessels in your nose, and they're very exposed to air, so they're very likely to rupture anyway. But with constant high pressure, people just start having bad nosebleeds, feeling lightheaded, and syncope. What's that one? Passing out, exactly. Fainting.
That's funny, I've had severe blood pressure and never had nosebleed. That's so weird.
Not everybody has everything.
Okay.
Yeah.
I'm just like, that's the first time I've ever heard that.
Yeah, anytime that there's any problem, like
I have the rest.
there's always like this many symptoms, and
Yeah.
because not everybody's the same.
Same.
Some people have things that other people don't. But yeah, so you had all the other ones you said?
Yeah, I said I don't have the, how'd you say,
Epistaxis?
and,
Yeah.
Syncope. I've never had that. I do get lightheaded,
Yeah.
and it's so weird because I'll have, when my blood pressure's high, I feel normal. I can't even tell, and then when it's
Yeah.
low, I have the headaches.
Well, yeah, when you have really low blood pressure too, you can also pass out or feel
Yeah.
lightheaded.
So mine fluctuates back and forth.
My face gets real red.
That's another thing too, because there's more pressure, more blood flow in that
That's how
face.
I feel in my head. Usually it's in my, she's
Like
in
pressure?
my face. Yeah.
Yeah. How do we diagnose hypertension? Well, it's by looking at the blood pressure, right? So there's the systolic number and the diastolic number, okay? You just need to know that those are the top and bottom. So the systolic is that top number, which we want to be around 120, right? And then the bottom number is that diastolic number, which we want to be under 80. Once it starts being 140 over 90, that's considered hypertension. Okay, consistently. Like, right, if you come in one time to the doctor's office and it's 140 over 90, they're not going to slap you with a diagnosis, right? They're going to have to check it over multiple times to make sure that that's actually what it is, not just maybe you just came from working out, or maybe you were anxious, or you got white coat syndrome or something. Does that make sense? So like everyone's blood pressure goes up, like when you're active or whatever, but it's like when you're at rest and it's consistently above that, that's when you get a diagnosis, if that makes sense. So at rest, like especially when you first wake up in the morning, is a really good time to check your blood pressure because it shouldn't be high if you just were in bed all night, right?
Oh yeah, mine be.
That's mine.
So that's the best time to check your blood pressure. Is like first thing in the morning, like before your feet hit the floor. Just check it, right? And that's a good indicator of what it is at rest. Any stress contributing to that? Being in school?
Mine was hereditary.
Yeah.
I've had every test possible. They're like, I cannot understand how your blood pressure is as high as it is. If you
Well,
get
yeah. I mean, what was that guy, Lance Armstrong, the biker dude? Like he's so fit, but he's still. There's some things you can only.
Yeah,
You can't help
I've
it.
tried everything. And it just, that's one of the things you can't get away from.
Treatment-wise, there's various different drug classes. Diuretics, these just reduce fluid. Anybody ever heard of a water pill? That's kind of like the street, like, huh? Well, that's more for prostate issues to help them pee around the prostate. Furosemide, yeah. So diuretics, they help reduce the fluid. Now, the reason why they want to do that is because it helps to get rid of the pressure, right? Think of like a water balloon. The more water you pump in there, the more pressure's in that balloon, right? You don't want it to rupture. So if you take water out of the water balloon, the pressure goes down, right? So that's kind of the idea, is help get rid of some extra fluid. Now, these are different classes. These aren't individual drugs themselves, but ACE inhibitors, beta blockers, ARBs, and calcium channel blockers, or CCBs, those are all different drug classes.
What's ARBs? What's
Angiotensin receptor blockers. I had to think about it. I was like, what is it? I'm just so used to the acronyms now that like I'm like, what is that?
When you said it, I was like, ARBs, okay.
ARBs, yeah, that's what we.
I think I've been on everything possible.
Yeah. They usually start you out with one, and then if it doesn't fix it, they'll add on another one, and then if that doesn't fix it, they add on another one. So,
I think I'm on beta blockers now. I'm on
beta. What do you take, if you don't mind sharing?
Losartan.
Losartan is an ARB.
Okay,
Mm-hmm.
and
Nevolol.
Yes.
That's a beta blocker.
Okay. So
And I know that just because of the endings.
Yeah.
So we'll talk about this at the end with the medications,
Okay.
but ARBs end in sartan,
Sartan,
like
okay.
losartan, valsartan,
Okay.
telmisartan, they all end in sartan. And then beta blockers, you actually could remember from the eye and ear. We talked about timolol for the eye, helps
Yeah.
decrease the blood pressure in the eye.
Okay.
So it ends in lol is a beta blocker. And then ACE inhibitors, again, we'll talk about all this a little bit later, but end in pril, so lisinopril, what else?
That's what I take.
That's
I
just,
can't take lisinopril. It about killed me.
it affects some people with a really bad cough. Yes?
This is like kind of unrelated, but like I used to have a essential tremor, and they would prescribe propranolol.
Yeah.
So like I don't know how that.
Yeah, so
that's
sometimes drugs are made to do one thing, but also cause other things. So like Benadryl, for example, that's meant for allergies,
It's like
but some people take it to sleep.
yeah.
Right, so not all drugs just do one thing, right? Does that make sense? So like they can be designed to treat a specific issue, and they might realize, oh, this also helps with this other stuff.
Okay.
Yeah, so that's kind of like off-label use
Yeah.
until they realize that like, oh, this actually helps consistently with this other problem, and then it becomes widely used for other stuff. So like propranolol wasn't designed to fix tremors; it was for heart stuff, but then they realized it was also helping, and now it's just given for that too.
Yeah.
So
That's same with Paxil. I'm on Paxil for hot flashes,
yeah.
but it's also psych.
Drugs are weird, man. That's why I'm trying to, like, it's really, really hard to, like, reduce the pharmacology to, like, the bare minimum because there's always things like that.
I like it.
So, like, I'm trying to just, like, if you see a drug, I want to teach you to recognize the endings and know what they're generally for. I don't need you to know the side effects. I don't need you to know where they work at the cellular level or which receptors they activate or, like, if it's metabolized by the liver or the kidneys or what the half-life, any of that stuff. Just, you see metoprolol. what does that fix?
Yeah.
That's for blood pressure. That's literally all. Like I've dumbed it down to as best as I possibly can. But just know that there's like tons and tons of drugs out there. I'm trying to just teach the most common ones. Okay? So like this is just like the tip of the iceberg. I'm not trying to overwhelm you. I know you probably don't believe that. You're probably like, she's just trying to make us feel. I'm really not, I promise. Like, I'm trying to just do the bare minimum, like the things that you'll see all the time. Like these are things you'll see all the time. And you need to have an idea of what those are, okay? Prognosis of this is usually a chronic issue, right? It's kind of a lifestyle problem that you kind of have to just treat all the time, right? It's not something you just take for a week and your blood pressure's fixed, right? You got to constantly take this stuff. All right, congestive heart failure, affectionately known as CHF. You'll see CHF a lot. This is specifically regarding the pumping ability of the heart. Okay, so we know the heart is a pump, squeezes out the stuff. So if the heart is damaged, like from a heart attack, for example, and it's no longer able to pump adequately, you can get what's called congestive heart failure. So let me just read this. So the etiology of this, like I said, anything that impairs the heart pumping, so it could be from a heart attack, it could be from coronary artery disease, which we haven't gotten to yet, but that's just where the arteries themselves are just messed up. You could have issues with your valves. All right, if you guys have done the homework, you can see the valves are what allow blood to go through the chambers and not back up, right? So if you have a faulty valve, it's like having a faulty door, right? The door doesn't close all the way, so the blood is like backtracking. It's like a stopped up sink. The fluid just can't go down. It's getting blocked up and like coming back up the sink, kind of like that. So there's different reasons that you could have pumping issues. These are just kind of the most common ones. Symptoms of this, dyspnea. Who remembers what dyspnea is?
Shortest breath.
Yep, so dys always means like some kind of dysfunction, right? Like it's bad, right? And then pnea, that has, like think of like the word pneumonia, it has to do with breathing, right? So dyspnea is difficulty breathing. Tachycardia, we just said this. What's tachycardia?
Increased heart rate.
Increased heart rate. So cardia obviously is heart. Tachy means too high, and then the alternative of that is brady. So bradycardia is heart rate that's too low. And again, we're looking at that 60 to 100 range. So bradycardia would be below 60, tachycardia would be above 100, and this is at rest, right? This is not considering like working out, because everyone's heart rate's going to go up when they work out. Increased respiratory rate, so breathing faster than normal. JVD. Who knows what that is? That's kind of a specialized thing, but I'm just curious. JVD stands for jugular vein distension. Your jugular is here. It's right next to your carotid, and this is what that looks like. So that, in case you're wondering, that's not what it's supposed to look like. If you can look at your own neck, you're not supposed to be able to see it. So what's happening here is, like I said, with the backed up sink, right? If the fluid isn't going through the heart at a normal pace, like it's just not pumping adequately, like the fluid is getting backed up. Right, like it should be going through in a nice cycle, but if it's not getting pumped out of the heart, it's going to be backed up in the body. And this is one of the first places that you can see the backup occurring, because it's, you know, one of these vessels connect to the heart, and if it's not able to go through the heart normally, it's going to, the fluid and the blood's going to start backing up into the neck. You'll start seeing swelling in the legs. Does that make sense? So it's like a backed up sink is the best way I can explain it. Edema in the ankles. You ever see people with like really swollen legs? They probably have heart issues. Okay, not necessarily, they could have something else, but it's very common people to have very swollen legs. Because think about it, like you have to work against gravity for your blood to go up your body, right? And if your pump isn't working and it's weak, it's going to be very difficult for it to pump against gravity. So the blood and the fluid just seem to kind of collect down there in the ankles. Does that make sense? And then there's LVH, which is called left ventricular hypertrophy, which I know that sounds like a scary word. So this is basically what that is. This is what your normal heart looks like. These are the chambers. You know, you've got your atriums on the top and your ventricles on the bottom. So when we say left ventricular hypertrophy, it's the ventricle, right, is hypertrophying, which means growing in size. So you can see how the muscle here is a lot thicker than it is over on this side. And that's because your muscle is literally trying to get stronger to push the fluid out, right? Now, but you can see there's a problem. See how much room for blood there is here? Room there is there. So the heart might be trying to compensate by getting stronger to pump better, but now the amount of available blood to pump has decreased. So it's kind of shooting itself in the foot a little bit. Did you have a question, Tina?
Yeah, so is this, almost the same as, enlarged heart?
Yeah, I mean that when you do like an echo, like looking at the structures of the heart, you'll see the enlargement, right? So like this is literally enlarging of the heart muscle. So
Isn't the left usually bigger anyway?
it is, but this is like extreme.
Yeah.
So the left ventricle, I know, like you probably think, oh, this is the right side, but it's backwards because you're facing the person, but it's the person's left side. So like the left would be over here, and if you're facing me, it looks like the right. So this ventricle here is the strongest because this is the one that pumps blood to the whole body, right? Once it leaves here, it goes through the aorta and goes to the rest of the body. So this one has to be the strongest. But if the pump is not working well, the heart's going to try and compensate, like I said, to grow stronger with this extra muscle to pump better. But now there's less space for blood to be. So you're going to have less blood that's pumped out with each beat. So now your heart has to beat faster to be able to get more blood. So it's kind of like this vicious cycle. Does that make sense? That's why this is like a chronic progressive disease, because your body's trying to compensate, but through the compensations, it's making things worse. Do you have a question, Tina?
Yeah, just one thing. Because it's on the left side, will that affect your lungs? Because I know the left side is your pulmonary side.
Yep.
So-
I mean, like I said, the backed up sink, right? So the pump is bad. So, the blood goes through all these different chambers, right? So if it's not getting out fast enough, it's going to start backing up into here, backing up into the lungs, backing up into this side, backing up into the neck, the jugular vein, backing up into the ankles. So people are likely to develop lung issues.
And pulmonary embolisms, or no?
Well, not necessarily an embolism, that's a clot, but you could start getting pulmonary hypertension, right? Build up tension in the lungs or fluid backing up into the lungs. So people who have congestive heart failure often have lung issues as well. So like that's why the difficulty breathing is there, right? Difficulty breathing because now you have all this fluid in your lungs because it's not getting out.
So basically you're drowning.
Kinda, yeah. This is a really bad thing to have, right? We don't want congestive heart failure. And it's called congestive because it has to do with fluid, right? So you know how when you get congested in your nose and it's like you can't breathe through your nose and like you just have all this fluid? That's the same idea. Like that's what's happening in your heart. It's just congested and everything's backing up. It can't get through because it's so congested. Okay? So hopefully that helps you remember, like think of your nasal congestion. That's literally what's happening in the heart and in the vessels. Okay? I know that's a lot. Like, trust me, I'm trying to break it down and take my time explaining this. So please just let me know if you have questions. How we diagnose this? Well, a big one is going to be the echocardiogram because you can actually like see this on the echocardiogram, right? The echocardiogram is like an ultrasound. You can see the structures. Another one you can obviously do an EKG. That just kind of tells you if like the rhythm is weird. Ejection fraction is a huge thing because remember, ejection fraction tells you how well the heart's pumping, right? How much blood is coming out with each beat. So as congestive heart failure gets worse, your ejection fraction is going to go down. Right, it's going to be able to pump less and less and less. And you asked about the lungs, Tina. An X-ray might show that there's fluid stuck in the lungs from it being backed up, right? Treatment-wise, there's a lot of different things that people do, but basically the whole goal is to decrease the heart's workload, right? We don't want to stress the heart out so bad that it like gives up and just like has a heart attack and it can't. So diuretics is going to be a big one, reducing fluid, right? Since the issue is congestion, try to get rid of as much fluid as possible to decrease that congestion, right? So then also vasodilators, that's going to just help open up the vessels. That's what we take, when your nasal passages are congested, you take vasodilators from the nose, right? That's essentially what's happening, is it allowing those passages to open up so you can breathe. And then digoxin, this is kind of an old drug. Anybody heard of digoxin? It's kind of old. They don't super always use it all the time anymore because we have good stuff, better stuff now, but it still is used. But digoxin is specifically used to help strengthen the contraction of the heart. So it actually like helps give the heart a boost to pump stronger. The reason we don't use it super a lot now is just because like it has an issue with people getting toxic levels. Like you have to constantly measure how much is in their bloodstream because it's just some drugs are more dangerous than others. That's why some are prescription and some are over the counter. right? This one just tends to be like people can get toxic levels, and it's just kind of a pain to constantly have to check and monitor it. So they try not to use that unless they have to. And yeah, prognosis is not great. It's a chronic condition. This isn't something you can fix. It's not going to go away in a week, and it's generally progressive because it tends to just get worse, unfortunately.
So they use it, if they can't get the fluid off the lungs, they use a chest tube, right?
A what?
Chest tube?
It depends on what's going on, but people could get like a drain, where they like the drain goes into their lungs and pulls out some of the fluid. That's like more severe. Obviously, if they're in the hospital, you might see those more common in the hospital because that's the reason they're there is because it's severe. At home, people typically don't have that. Typically people will have like oxygen tanks at home if they're having like if they're feeling winded or things like that. Yeah. Where did my stuff go for this one? It's gone.
It shows it on mine.
That's weird.
It's tiny, but it's there. Like,
That's strange.
you can borrow mine.
Can I just borrow your computer from one side? That's super weird. I'll see if I can fix that. I'm not sure why it's doing that. I'll give it right back to you.
You're fine.
Okay, so cor pulmonale. This one is also a heart enlargement, but generally it's going to be the other side. So this was left ventricular hypertrophy. With cor pulmonale, the right side is actually going to be enlarged, and this is due to there being lung issues. So with congestive heart failure, you asked about the lungs, Tina. The lung problems are secondary to the heart problems, right? You have all these heart issues, and it turns into lung problems. With cor pulmonale, it's the exact opposite, right? So you have lung issues first that eventually cause heart issues, right? The lungs and the heart are very intimately connected because the pathway through the heart, I tried to send you guys that video so you could see, like the blood comes through the body, goes into the first half of the heart, then it goes into the lungs to get oxygen, then it comes back into the heart. So if you have heart issues, you might have lung issues. If you have lung issues, you might get heart issues. Does that make sense? So with this one, someone had lung issues first, some kind of lung disease, which causes the pressure to go back to the heart. Right, and it would be this side of the heart that has the problem because this is what goes to the lungs next. So the blood comes from the body, goes to this side. After this side goes to the lungs, then goes to this side, then goes to the rest of the body. So if you're having lung issues here, it's going to be backed up into this side. Does that make sense? Where are we at? So yeah, it's basically the same idea, just on a different half of side of the heart. It's stretching out, it's losing its elasticity. With this condition, people are going to have chronic hypoxia. Anybody know what hypoxia is? What's hypoxia? Let's break it down. What's hypo mean? Low, and oxia is oxygen. So low oxygen, and that's because they have lung issues, right? So whatever lung issues they're having, the lungs aren't able to supply the oxygen to the heart, which means that the whole body isn't getting oxygen very well. So chronic hypoxia, these people are definitely going to be on oxygen. If they're sent home, they're going to have oxygen tanks. Now, what the body does, we talked about how the body tries to compensate for stuff, like with the growing of the ventricle to make it stronger. One of the things the body does to compensate for that hypoxia is by creating more red blood cells. Why do you think the body would try to create more red blood cells? Exactly, because the red blood cells are the ones that carry and deliver the oxygen. So the body's like, okay, we don't have enough oxygen. Maybe let's create more red blood cells so we can get more oxygen. Great thought, but that's not the problem, right? You're not anemic, right? The issue isn't anemia. So now we have all these red blood cells, which causes its own problem because now the blood is really thick. The blood is supposed to be like watery so it can flow. If it's got way more red blood cells than normal, now it's really thick. And so like thick blood is kind of harder to pump and flow, so that creates its own issues. So symptoms of this, obviously difficulty breathing is going to be up there because it's the lung issues. You're also going to have that jugular vein distension as well, just because, again, we're having build-up issues. We're not able to flow through. Edema as well. So if you just look at someone and you see they had jugular vein distension and edema, you don't really know if they had cor pulmonale or congestive heart failure. You just know that they're having pumping issues. You don't know which came first, the chicken or the egg. Like, did the lung issues happen first or did the heart issues happen first? Does that make sense? So diagnosis-wise, obviously they're going to try and see if you have any pulmonary diseases. They can do some X-rays to see the fluid building up around the heart and the lungs. They'll do an echo, obviously, to look at what the heart looks like. Treatment-wise, now this is where it's a little bit different. They're going to treat the lungs, right? Because the issue is with the lungs, right? The problem is with the lungs. The heart is kind of like a secondary casualty. So if you fix the lung issue, the heart issue should fix itself. So bronchodilators, which we talked about in respiratory, is what's going to open up the lungs to breathe better, right? We talked about that with asthma and COPD, bronchodilators, those inhalers, right? So that's going to be a big part of the treatment for this. And then also diuretics, just getting rid of that fluid. Same thing with CHF, the prognosis is not great. It's chronic and progressive, especially if you don't get it treated well. If you just kind of like ignore it, it's just going to progressively get worse. The other thing, I don't think this is on PowerPoint, but that increase in red blood cells, the term for that is polycythemia. So if you see polycythemia, that's what that means, is that increase in red blood cells.
Can you spell it, please?
Poly is P-O-L-Y, which poly means multiple, right? Cyte is C-Y-T-H-E-M-I-A, so polycythemia. And hemia, what does hemia mean in medical terminology? Blood, right? And cyte means cell, so lots of blood cells, essentially.
So polycyte?
Polycythemia. Polycythemia. And I'm sorry, I don't know why it's blank on mine. That's super weird. And then this was just a diagram to show you the pathway of the blood again. So it goes into the heart, goes to the lungs, goes back to the heart. So that's why if you have lung issues, it affects the heart. That's all. All right. After this one, we'll take a break, okay? All right, pericarditis. This is going to be some kind of inflammation, right? We know itis. And then card has to do with cardio. So, and then peri, I kind of remember this like, it means like around. So I think of like perimeter, like the perimeter is something that goes around something. So pericarditis is actually the inflammation of the sac that surrounds the heart. Your heart is actually encompassed by a sac, which is called the pericardium. So when that's inflamed, it's called pericarditis, okay? I think here's a picture of it. Yep, so this is the pericardium. It's just like this little membrane that surrounds the heart. If that gets irritated or inflamed, that's pericarditis. This usually happens due to some kind of infection, viruses or bacteria from something. And when that sac is inflamed, it just makes it awkward and hard for the heart to beat because it's like being restricted by this like inflamed thing kind of pressing on it. Does that make sense? So symptoms of this, you might have fever, obviously, because it's an infection. Whenever you have an infection, fever is a potential symptom. Chest pain, just because it hurts, like that inflammation hurts, especially when you inhale, just because it puts more pressure. Like when your heart is nestled right in between your lungs, right? So when you breathe in, it's gonna like squeeze the heart even more, and so it's gonna like make it painful. Dyspnea, that's just a difficulty breathing. And you might hear, again, a friction rub. That's when you're listening with your stethoscope and you hear like the sound. That's the sound of the sac rubbing against the heart. And so that you shouldn't hear that. Diagnostic-wise, you can do a blood study to see if you can get... A blood study will just tell you like if there's bacteria or something in the bloodstream, right, if that's what's causing that. Anytime there's an infection, I don't care what type of infection it is, you're always going to have increased white blood cells. Because why? Why do you think they would have increased white blood cells?
Because that's, your white blood cells is your infection.
They're the ones that fight infection, right? That's your immune system right there. So whenever you have an infection of any kind, your white blood cells are always going to increase because your body's trying to crank out more of them to fight whatever it is, whether it's virus, bacteria, or whatever. And then again, because this is inflammation, you're going to have increased ESR or CRP, both, right? Because that just is a marker of inflammation. It's not going to tell you, it's the heart sac that's inflamed. It would be nice if it did that, but it just says, yes, there is inflammation. So the treatment, obviously, is to reduce the inflammation, since that's literally the problem. And the mainstay of treatment for reducing inflammation is always steroids, right? Steroids. The purpose of those is to decrease inflammation. That's what they're for. And antibiotics if it's bacterial. If it's viral, that won't work. And this is an acute disease. This isn't something chronic. It's an infection, so once you get over the infection, you should be back to normal. Any questions about this one? Why don't you guys go ahead and take a break? I don't want your brains to explode. I know cardiac is difficult. Let's be back here at like 2:07. Tina, this is probably going to be your easiest unit.
This is like one of my favorite.
Yeah.
Same.
Well, I mean, to work in telemetry, it'd have to be, you know.
Yeah.
I know cardiac is generally very difficult for a lot of people, but you definitely have an advantage in this, having worked in telemetry for sure.
Yeah. And I like the plumbing. I like the plumbing more than the electrical, but I mean I like them both. So.
Just spilled coffee on myself. Sorry.
I'm
I know how to drink out of a cup.
Got a hole in your lip?
Huh?
So you got a hole in your lip?
Maybe.
I just got done doing.
I love they just have that little cup in there. We used to have to keep cups in everywhere because my little sister. I still feel like we have to keep
This is
cups.
technically my daughter's stuff, but it's turned into mine.
Right. So why did my cardiologist tell me that metoprolol is not a blood pressure pill?
I mean, it is. They don't typically give that to start, and you guys don't need to know this. Like, generally, they don't give beta blockers as a first-line treatment for hypertension. They usually start with something else. Unless someone has heart failure, then they do. And that's way more, like, advanced than you guys need to know. But metoprolol, generally, they give beta blockers for, like, heart rate issues.
Yeah, that's what they gave me the metoprolol to kind of manage my heart
Yeah.
rhythm.
So this is gonna be more information than you need, but beta blockers, the reason they're called beta blockers is because they block beta receptors, okay? You have beta receptors on your heart, and you have beta receptors on your lungs. There's beta 1 receptors and beta 2 receptors. Metoprolol, like I said, beta blocker, so they block that receptor, that keeps the heart rate low, because when you activate a receptor, it activates it, makes it go, right? So like when it's activated, your heart rate's gonna speed up. So if that receptor is blocked, then the heart rate will stay low, right? So generally, people who have like tachycardia, for example, or have you ever heard of POTS, postural orthostatic tachycardia syndrome?
I've heard of orthostatic
Yeah.
vitals.
So beta blockers are really good for dealing with heart rate. So that's why they're generally not given as a first-line treatment for blood pressure. But people that are on like multiple blood pressure meds, they'll eventually put them on a beta blocker as well.
Okay, well I'm on lisinopril and metoprolol.
Yeah. Well, so it is for blood pressure, but it's not just for blood pressure. That might have been like what he meant, or she. I don't know if you're talking guy or girl. But generally, someone will put you on a ACE or an ARB or a calcium channel blocker first instead of a beta blocker. Unless it's heart failure related, then they'll put someone on a beta blocker first. But like I said, you don't need to know all of that at all. That's just too much.
That is too much for me.
Well, I know
I
you
like
kind of have a
to-
background and are interested, but I wouldn't want to share all of that and overwhelm people
Right.
because they'd be like, blah, you know. So like I said, I literally am doing my best to try and like keep it simple, but it's just very hard to do that when there's just so much information. Like trying to cram every body system into one semester
Yeah, it's a lot.
is insane. Right, when I was in nursing school, they would split this up over several semesters. Like we'd spend like a whole exam just on cardio, like, and that's it. Right?
Yeah,
It was
it's a
literally
lot.
just
My
cardio.
last AMP2 exam was blood vessels, and yeah, it was just like everything. No, it was so much information.
Yeah. So at least you've had some of that already. Helpful.
Yeah, but it was a lot.
Yeah. So I'm kind of in a rough spot with this class because not everyone has taken medical terminology or it's been so long. Not everyone has taken A&P or it's been so long. So I'm trying to teach med term, A&P, pharmacology, and disease all in one semester, which is basically 4 classes in one, which is insane. So I beat my head against the wall a lot trying to figure out how I can like set you guys up for success and actually learn things without like absolutely killing you.
Well, it helps if you've already had the anatomy.
For sure.
because
Not everybody
it-
has them,
No, and
which is
because
a
like me
struggle.
and her, like when you go to talking, I like to automatically remember what things are. So
Yeah.
I've taken it twice.
Yeah.
I've tried to do nursing and all the hoops and stuff. This last time I gave up. I said I'm not jumping through hoops.
Yeah.
It's ridiculous.
That's why I try to throw in as many medical terms as possible and then explain what they mean because I know some people haven't taken med term or they're taking it concurrently right now or it's been so long they don't remember.
Right.
And I'm like, when you read charts, they're not going to explain to you what the words
No.
mean. They're just going to use them. So, and then I try to put some like a little bit of A&P in the homework to kind of as a refresher
Refresher, yeah.
because some of it you
Well,
like you
some
really
of it,
have to
if I
understand.
don't know what it is, then I'll Google it.
Oh yeah, I use osmosis like to because I don't know if you guys have heard of osmosis on YouTube. Like they do a really good job explaining A&P. It's like I don't need you guys to know like so much of the A&P like down to the cell, but like there is like you have to have some kind of understanding. Otherwise, you don't understand how the disease works.
Right.
Like if you didn't understand how the blood goes through the heart, like you have no idea what congestive heart failure is, and then like have no idea like what symptoms. Does that make sense? So it's like I'm trying to do a review, but
on top of
yeah. So I totally understand that it's a lot. Like I get it. Like it's basically 4 classes in one, and it's a lot. Like I learned all the body systems over my entire nursing career, like or not career, my entire nursing program.
Yeah.
We would never have done all of
No.
them in one.
Well, that's like when
So-
she talks about it being broke down into 7 weeks. I'm like, how did you do that?
Yeah,
in
so-
7 weeks. That's a
Horrible.
lot.
Never
So
done that.
I understand. I'm with you. I get it. If you guys have any ideas how to make it better, I'm all ears. I've done this is my second time doing this, and I've changed the curriculum so many times because when I came into this position, it was insane. Like the amount of stuff that you guys had, it was absolutely insane. I was like, I don't even know what half the stuff is, like because it's
Yeah.
like it's not important, like it was like pharmacology down to the cellular level, like which cells and which receptors is activated. Like you don't need to know.
No.
Like I literally only need you to be able to be like, what is this drug for? That's all.
Yeah.
But like it was too late for me to like change all of that
Change it, yeah.
because I came in like a week before the class started. So I was like changing it on the fly, and so like now this semester is a lot better because most of it is gotten rid of,
Yeah.
but it's
I
still.
mean, the way you got it's working. I mean, it's understandable.
So I'm very sympathetic to the challenge of this class. I really don't know what a better answer
The
is.
main thing is if you've not had anatomy at
Yeah.
some point,
Yeah,
then
it's be very,
you're
very
gonna
challenging.
struggle because you don't know what half this stuff is.
Yeah.
So the other issue is Chattanooga State's A&P1 doesn't cover this.
No.
What does
it's
it cover?
only in 2. Yeah.
You only do like some of the systems, and A&P2 is the rest of
The rest
it.
of it.
Oh, I
yeah.
see.
So I wouldn't know any of this if I only took A&P1.
Well, that's what it was like for me when I took A&P 1 and 2. Again, because it's too much to cover in one, so they have to split them up, which is my point. Like I'm having to do all of them in one, right? And not all the body systems, but every disease.
Yeah.
And like that's why I've cut some stuff out of the book because I'm like it's just too much. So I've cut out things in there that like are kind of rare or like things that I don't even really know what they are. Like I'm trying to focus on just like the common stuff that you'll see all the time. But yeah, please, if you have questions or suggestions, I'm always open to that because I understand.
My heart rate's 47.
I forgot. I don't know if I can hear.
That's fine.
Oh, okay.
Bill, I should have asked for certain stuff.
No, I don't care about
I
that.
feel like high risk and knowing that I'm on something.
Yeah, well that's why the metoprolol is decreasing your heart rate. Yeah.
Yeah.
But I'm good.
If you feel fine, then it's fine.
Okay.
We're talking about this in a second, but bradycardia.
I've actually seen people's heart rates in the 30s.
Mm-hmm. My husband's heart rate when he sleeps drops into the 30s,
Yeah.
but his heart is like
Is
really
he a
strong.
runner?
I mean, he runs, but he's just very cardiovascularly fit.
Yeah. Runners,
Yeah.
athletics,
Yeah.
their heart rate usually drops in the 30s.
Yeah, so bradycardia, you know, a low heart rate, anything below 60, is only a problem if it's a problem, right? So if you're an athlete and your heart is like healthy, your heart rate's gonna be lower because you don't have to pump as often because your ejection fraction is probably like insanely good. So you only need one heartbeat to squirt out as much blood as it would take someone else's like 5 beats, right?
Okay.
So if you have no symptoms and you feel great and your heart rate's in the 40s, great. But if you're feeling lightheaded and dizzy and kind of sickly, then it's a problem, right? Because
40s.
yeah, I know.
Like 40?
yeah.
Yeah.
I've
Mine's
never
47
seen
right now.
what?
Yeah, it can be normal if you're healthy. If you're not healthy, like your heart is just weak and giving out and dying,
Yeah,
40 is bad.
Oh my goodness, I've never.
medications do.
Like every time I get my blood pressure
Wow.
taken, it's always crazy low, and
Yeah.
they don't care because
Yeah, no.
if you're feeling fine, they're like
Low
"Oh,
blood
no,
pressure
no."
is good
Yeah,
if it's not a problem,
yeah.
right? Like if you feel fine and you're healthy and you're athletic, you're gonna have a lower blood
Sure,
pressure.
just like
Right.
okay, whatever.
It's only a bad thing if it's causing bad things. So my blood pressure generally hangs around like 110/60, which is low, but I feel fine, right? If I were getting lightheaded and, you know, passing out and feeling weak, then it would be bad, right? Anyways, that was kind of a tangent. Let's bring it back in here. All right, myocarditis. This is inflammation of the heart muscle itself. So we just talked about pericarditis, which was inflammation of the sac. Right now we're going to talk about inflammation of the heart, like actually the heart. And myo, again, remember, means muscle. So the muscle of the heart is inflamed. Okay. Again, this is also due to some kind of infection, virus, fungi, bacteria, one of those options. Also exposure to toxins, like street drugs or poisons, sometimes autoimmune conditions. If your immune system is attacking itself in the heart, that can happen as well. Radiation also, weirdly, like, you know, chemoradiation sometimes can cause this, some kind of weird reaction. So there's lots of different reasons why your heart can respond this way. But symptoms-wise, heart palpitations. Do you know what palpitations are?
Yeah.
It's like your heart just beating kind of weird. Like you can sometimes feel them too. This happens when I drink caffeine. I can feel my heart rate kind of being weird and funky. Like I can feel it.
It is.
Scary.
It's scary. I'm just kind of used to it. I know it's related to. I'm like, ah, there it goes.
Mine's going on so.
It's like, oh, my heart's doing a little dance today.
It kind of feels like,
I get scared.
like, it kind of feels like flutter.
Yeah. Yeah.
Fluttering.
I just know that it's
Or
related to
vibration.
caffeine.
Like,
Yeah.
vibration.
It's kind of vibrating in there, doing a little dance.
I got my runaway heart. I just hold it for a minute and then I just calm down.
Fatigue also, just this is related to your heart just having to work harder because it's inflamed, and also just when you're sick you feel tired. Difficulty breathing, again, because if your heart is messed up, what's going to get backed up into? The lungs, right? And then obviously just chest tenderness, because when something is swollen it hurts. Like if you sprain your ankle and it's inflamed, that hurts. Inflammation hurts. Diagnosis, well, it's an infection, so we're going to have elevated white blood cells, right? There's inflammation, so we're going to have increased ESR. Also, we could have increased cardiac enzymes, like the same ones with a heart attack, right? Because the heart muscle is being attacked and damaged, right? So in the case of a heart attack, it was dying from lack of oxygen. In this case, it's just inflamed because of some kind of infection. But either way, the heart muscle is being affected. So it's releasing those same enzymes. Treatment for this, you're just going to address the issue. So if it's a bacterial problem, you're going to give them antibiotics. Resting is going to be a big one, just to kind of like give the heart a break, you know, while it's recovering. And then since it's inflammation, what are we going to give?
Steroids.
Right. Thank you. Next, you're like, I got this.
Hold on, wait.
So anti-inflammatories are kind of like a broad term, right? Steroids can fall under that, right?
I do have a quick question.
Yeah.
So what is it called I don't know if y'all ever experienced this, and it happens like it's rare. You'll breathe in one time and you feel a sharp, like somebody, like a stab in your chest. And it sometimes, like every time you breathe, it kind of hurts.
Mhm.
You know, do you know what I'm talking about? No,
I mean,
you never
I know
experienced
what you're talking about. I mean, it could just be so many different things.
I
Like,
got told it was that your lung was sticking to your rib cage.
Oh.
listen, I don't
Wow.
know without doing like tests.
Yeah.
You know, like I get those when I'm running. Like I get the stitch.
Yeah. Okay. Yeah.
Yeah.
That's yeah.
Yeah, I don't
Oh.
know. I don't know. It's sometimes it could actually just be a musculoskeletal issue. Like if you have a pulled muscle in your rib, you know, it could like get hurt when you inflate your lungs. I don't know. It could be.
As long as it goes away.
No,
Yeah,
it
it
goes
goes-
right here,
Yeah.
They be up in here.
and it
sometimes
feels like a bunch of,
Yeah.
like your hand falls asleep, but it can be pleurisy.
So
Yeah.
I don't know. I don't have X-ray vision to see. Sorry. This is an acute condition, right? Just like pericarditis, it's an infection, right? So infections are generally acute, right? The infection gets better and it goes away, right? It could develop into chronic issues if the heart is like damaged so bad that now the heart is just damaged forever, right? If you don't treat it, right, and it like permanently damages the heart tissue. Does that make sense? So it could be acute or it could turn into chronic problems. And so that's kind of a broad range. And again, this is what it'll look like. You can see that there's like an infection. It's causing the heart muscle to like swell up and get irritated. So you can see how like if this doesn't get dealt with and it causes chronic inflammation, then it's like having heart failure, right, from an infection type deal. All right, the last one we have is endocarditis. So we've seen pericarditis, myocarditis, and now endocarditis. Endo is talking about the inflammation of the inner lining of the heart. So like the inner lining would be like all the stuff inside, right? So like the lining of the chambers and like the valves as well. Okay, so that's why it's endo, like inner. This is also due to some kind of infection. Generally, there's bacteria in the bloodstream that gets into the heart. Generally, anything in the bloodstream is going to get to the heart because the heart is what pumps the blood, right? So if you have an infection in your bloodstream, it's going to make its way to the heart. Big risk factors for this are IV drug users, and that's because they're injecting stuff straight into their blood vessels, right? And if there's any like germs or whatever on the needles, it gets into the bloodstream and then it gets to where? The heart, right? Also, poor dental hygiene. That sounds kind of like a random thing, but I don't know if you guys ever had like invasive dental procedures. They usually put you on an antibiotic first, right? Just for whatever reason, like infections in the mouth tend to make its way directly to the heart for some reason. There's like a direct path between the two, so they tend to like travel because they're very close. Like this isn't that far away, right? So that's generally people that don't get regular cleanings or have really bad plaque buildup or maybe have root canals or teeth that are rotting and then they don't get them fixed. It's a kind of a direct line to the heart as well. So take care of your teeth. Yay.
Maybe it wasn't so expensive.
I know.
Most people would be able
Do
to
your
do that.
best, floss and brush. That's free. Okay. Listerine. Symptoms of this, again, it's an infection. So fever, chills, night sweats, just feeling weak. And again, anorexia, when you see that, it's not talking about the eating disorder. Okay? Like, it's talking about just not eating. Right? So that can be confusing. People see anorexia and it's like, I don't have an eating disorder. It just means like not eating and losing weight. Okay? And then fatigue. So these are just kind of generic feeling blah symptoms. How they diagnose this is they're going to do an echo, right? Because an echo shows you, like you can see the heart, right? That you can see the inside of it. You actually start to grow these weird vegetative growths. They often call them cauliflower growths because they look like kind of like these white little cauliflowers. They're not actually cauliflower, but they look like it on a picture. So you can kind of see, this isn't the greatest picture because it doesn't look like cauliflower, but there's these weird, this is basically the bacterial building up on the valves, okay? So that's bad because now the valves can't work, right? Like the valves are unable to function properly, which can lead to issues, right? If the valves can't shut properly, the blood flow is going to start backing up. So it could lead to congestion issues, right, if it's not treated, right? You see how it's all kind of related? Treatment for this, you're going to be definitely put on IV antibiotics. This is like going straight to your bloodstream. So this is like you're going to be hospitalized for this, okay? Because it's like severe. You need to be dealt with in a hospital. They might even have to do surgical replacement of the valves because they've been damaged from the bacteria, right? They do have prosthetic valves. Some people are just born with valve issues. Like some people are born with different heart conditions. Some of you've heard of like people having holes in their heart when they're born or whatever. Like there's lots of different things people can be born with. Valve issues is another one. So they have prosthetics that work really well. They just work like a door. So that's that. That's the last one of those itises. All right. Then we have rheumatic fever. Anytime you see like rheumatic or rheum or like rheumatism, that's generally referring to like some kind of autoimmune problem. Okay, you remember rheumatoid arthritis? That was an autoimmune disease. And then there was the drug class, the DMARDs. I don't know if I remember that from like back in immune, but that was the disease-modifying anti-rheumatic drugs. And so like it's for people with autoimmune disorders. So I don't know really why, but rheum tends to mean like autoimmune problems. So what's happening here is they're having like an autoimmune reaction, and this is weirdly generally happens after someone's had strep throat. Okay, so one of the reasons why they really want you to treat strep is not just because to feel better, but for some reason people like after having strep throat within like a couple weeks, you can start developing rheumatic fever, which is where like you have the antibodies that got formed against strep throat for some reason decide, hey, I'm going to start attacking our body now, and it's kind of a weird thing that happens. Kids tend to get this a lot because they get strep, right? So that's why it's important to treat your kids if they get that. So what's getting affected is the joints and the heart itself. So these antibodies that were formed to attack the strep are now attacking your joints. So it kind of looks like someone's having rheumatoid arthritis, right? Because remember, rheumatoid arthritis was attacking the joints. You start having like the deformities and the pain in the joints, and the heart itself. So you also develop the weird growths the same way with the endocarditis because the antibodies are attacking the heart itself. So it's kind of a weird thing that happens. So symptoms-wise, they have a history of strep throat. They'll have fever, polyarthritis. What do you think that means? Poly. Yeah, poly is multiple, right? So multiple joints. Arth is the joints and itis is inflammation. So multiple joints that are inflamed. So it's kind of like rheumatoid arthritis. Edema is just the swelling, redness. They'll have limited range of motion with their arms and legs just because the joints hurt, right? So they're not going to be able to like move freely. So kids that all of a sudden are like acting like they're hurting everywhere and they were just sick, that's probably what's happening. Diagnostic wise, they can also do that cardiac enzymes thing because if their heart is being attacked, and damaged, those troponins and everything else are going to be released the same way. And again, since it's related to an infection, there's going to be elevated white blood cells, and since it's inflammation, there's going to be elevated ESR and also CRP probably. Treatment. I mean, antibiotics, right? Definitely to address the strep infection. Probably also steroids too, since it's autoimmune and inflammation thing. Prognosis-wise, since this is like related to an infection, it generally is acute, usually resolved in a few months. It is a longer, it's not like you get better in a week. It takes a couple months to get better, kind of like mono. But if it's not addressed, it can permanently damage those valves since it is attacking, the heart and the joints as well. So they may need a valve replacement as well if it's not addressed. So that's what rheumatic fever. And since we're talking about the valves, we'll talk about mitral stenosis. The mitral is referring to the mitral valve. So let me go back up here. You can see the valves here. This is the mitral valve. Which also, I don't know why they do this, but it has two names. You might have seen bicuspid valve. I don't know why things have multiple names. It's annoying. So you could see mitral valve or bicuspid valve. That's the same thing. And then this one is the tricuspid valve. whatever. So mitral stenosis is a hardening of the mitral valve. Okay, so obviously we want the valve to be very elastic because it needs to open and shut rapidly every time you have a beat, right? And if it's starting to get hard, it's not going to be able to open and close good. So when it hardens like that, it doesn't completely close, which allows the blood to kind of backflow, right, and build up congestion as well because it's just not exiting the heart properly. So you're going to have a lot of symptoms of like with the congestion issues. So exertional dyspnea, that means difficulty breathing when you're exerting yourself, you know, so like you're trying to walk or run, and you go up a flight of stairs and you just feel like you're out of breath, feeling tired. Interestingly, like cough, because it kind of like, I don't really know why cough is related, but like sometimes, I don't know, some of you say you have those palpitations. Do you ever feel like you need to cough when your heart is like, I have that too, like when my heart is like doing that weird little palpitation thing, it makes me feel like it kind of tickles almost, and like I need to cough. Don't really understand why that is, but it's related to that, with the palpitations. So when someone has this, you'll actually be able to hear it, right? When you're listening to someone's heart, the thing that's making the lub-dub sound is the sound of the valves opening and shutting, right? So whenever you hear lub-dub, that's the valves opening and shutting. That's what's making that noise. Like if you open and close a door, it's going to make a sound, right? So when there's something wrong with the valves, you're going to hear a murmur. And a murmur is just, it's like a weird, it doesn't sound like the normal lub-dub, okay? It has like kind of a weird sound. It doesn't sound like it's supposed to. And then if you hear a murmur and they're having all these symptoms, they'll just do an echo, right? To look at the heart, use that ultrasound to see what's going on, and they can see that the valves are opening and shutting correctly, okay? Goal-wise, decreasing the workload of the heart. Remember, like the valves, if they're not shutting right, the blood can start backtracking and like backing up. So decreasing the workload means getting rid of extra fluid. So they might give someone diuretics. If it's really bad, they'll probably do a valve replacement as well, like we've talked about with the other ones. Prognosis-wise, this isn't something that like magically gets better, right? It's slowly progressive, so it's going to slowly just get worse and worse until you like have to replace the valve, or if it's just left untreated, it can lead to heart failure, right? Like the congestive heart failure. We talked about how there could be multiple causes for congestive heart failure. It could be heart attack, it could be valve issues, but something is impairing or impeding the heart from pumping correctly. Do you have a question, Tina? You looked at me. Okay. So here, again, sorry with the picture quality. This is a normal mitral valve. You can see that it's nice and open. Well, it sort of looks better on the screen up there than it does on my computer. And then with mitral stenosis, you can see that it's more narrow, so it's kind of hard and stiff, so it's not able to just work as well. All right, arrhythmia. Anytime there's an A before something, it just means like bad. Like there's normal and abnormal, right? So abnormal means not normal. So rhythm and then arrhythmia just means it's not in rhythm. Okay, so an arrhythmia is it's not doing the correct rhythm it should be. So any deviation from a normal heart rhythm. There's tons of different types of arrhythmias. You don't need to know what they are, but you should be able to recognize the names of them. And she's like, oh, that's an arrhythmia. Okay, and we'll talk about that in a second. So basically, there's some kind of disturbance happening with the electrical system. In the heart, you have something called the SA node. The SA node is just what's responsible for keeping the pace of the heart, right? Literally, the SA node is like the boss telling the heart when to beat and how to beat. Okay, so if something gets messed up with that, like the rhythm's gonna be all weird. The symptoms of this, lots of palpitations, heart rate changing, so like maybe it's fluctuating a lot, maybe like, you know those little finger probes, like the O2 sats where you can like look at your heart rate? Oh, you have one right now. Perfect. You want to show people? You put your finger in it and then it tells you like what your heart rate is. So generally like it should stay pretty stable. It might fluctuate a few beats, but if it's like dropping to 40 and then going up to like 120 and then into 80, like that's an arrhythmia, right? Like it's just the rhythm is constantly changing. If it's real bad, you might pass out, that's syncope. Skipped beats, like you feel like, going lub-dub, 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 lub-dub. You feel like the skipped beat there. Diagnosis, EKG, if if it's happening right then. If they can't catch it right that minute, Holter monitor, like what she's got. They wear it at home, does an extended period of time. Treatment-wise, it kind of just depends on how bad it is. So depending on the arrhythmia, there are arrhythmias that are really life-threatening, that like you will die if this isn't corrected, and there are arrhythmias that are like, this is probably fine, right? So the really bad ones are treated with cardioversion, or basically a shock, like a defibrillator, like you see in the movies, people like, clear, zap, that's cardioversion, right, a defibrillator, where they send like that shock to restart the heart, right? They can also do something called an ablation. This is where they burn away cells in the heart that are firing irregularly. So sometimes you can have some cells in your heart that are like rebels and not listening to the SA node, which is what tells the heart when to beat, and they're just like going off on their own and doing their own thing. So if you burn those away, then your heart should go back to normal. That's an ablation. You can have a pacemaker. Anybody heard of a pacemaker before? It's literally like it overrides the SA node. So if your SA node is just crazy and it's just doing who knows what, they can give you a pacemaker, and that becomes like the new SA node, so to speak, which tells your heart when to beat. It determines the rate of your heart. Then there's also drugs that you can take that help make your heart more regular. So there's lots of different ways to go about this. And again, prognosis is just going to depend on what type it is. There are arrhythmias that are perfectly fine to live with. You don't really need much treatment. And then there's life-threatening ones. This is, again, what you don't need to memorize any of this or anything, but like you can see, like this is like a normal heartbeat, like lub, dub, and then tachycardia, like you see it's faster. There's like more of them than here, and then bradycardia is slower, so there's less heartbeats. So these are, you don't need to look at that. These are kind of like the most common rhythm issues. And again, you don't need to know really too much about them, just be able to recognize that they're rhythm problems. So whenever someone has like a normal rhythm, that's called normal sinus. That's good, that's great. Sinus bradycardia, talked about this. It's when it's below the normal 60 to 100. And again, it's only bad if it's bad, right? If you're super in shape, your heart rate's probably gonna be below 60, but that's good. It just means your heart's functioning really well. Tachycardia is when it's too fast, so over 100, we talked about that already. All right, so now there's atrial fibrillation. This is one of those that is definitely you're gonna want to treat. Okay, so atrial fibrillation is when the atrium, hence why atrial fibrillation, is kind of just twitching. Instead of doing a nice pump, it's kind of just going like this all the time. So it's like, it's just not functioning well. It's like normally you want it to fill and then squeeze. Fill and then squeeze. But it's just kind of like trembling all the time, right? So that's suboptimal, right? Yeah. So the problem with this is that atrial fibrillation tends to cause clots. And the reason being, if you think about a river that's fast flowing, the water tends to stay pretty clear because the water's moving quickly, versus like a lake that's just sitting there stagnant. There tends to be like a buildup of like scum on the surface of the water, right? Like kind of like this weird film, right? So the same thing with the blood. When the blood is moving along quickly, being pumped in this constant cycle as it should be, the blood doesn't have time to like get stale and stagnant and clumpy, right? But if it's just kind of like sitting still and not moving correctly, like with the fibrillating heart, like it's not really being pumped out quickly, it's just kind of sitting there and pooling, these clots tend to form, okay? And clots are bad, right? Because if one goes to your heart, you could have a heart attack. If one goes to your lungs, that's a pulmonary embolism. If one goes to your brain, what do we call that? Stroke, right? So all three of those things are not desirable, right? You can die from any one of those three. So definitely we're going to give these people anticoagulants, right? So preventing clots, right? That's the big thing with AFib is the clot problem, okay? Ventricular fibrillation, this is now where the ventricles are doing that instead of the atrium. The atrium are the top ones, the ventricles are the bottom ones. And the ventricles are, I don't want to say more important because it's all important, but they're kind of more important because they're the ones that have to squeeze really hard to go like either to the lungs or to the rest of the body. So if these guys aren't working well, then you have more serious problems. This one is life-threatening. For short, you might hear it be called VFib or AFib.
Defib, defib.
Yeah, so that's a nice little rhyme. If someone has VFib, you give them a defib, which is the defibrillator, which is the shock, right? So it's kind of a fun little thing to say. VFib, defib. So people can die from this. If you're in the office and you do an EKG and someone has VFib, like, okay, we're calling an ambulance and you're getting a defibrillator. Same thing with ventricular tachycardia. People might also call it VTAC. This one's also life-threatening. It's just like, it's going way too fast. Yeah. And Tina, you know probably more about this than I do, honestly, because you've worked in telemetry and that was like your thing. But yeah, these two are very bad. And then there are also various types of heart blocks, and you don't need to know all of that because it gets very intense, but there's 1st degree, 2nd degree, 3rd degree. Obviously, 1st degree is less bad than 3rd degree, okay? And then basically how we deal with these is usually give someone a pacemaker, just so it can override the SA node, because generally like their heart's just out of control, they can't figure out how to beat right, so the pacemaker will do that for them, okay? So just being able to recognize that these are different types of rhythms and knowing for sure that clots are an issue, because you will see this very common. Like you'll see all sorts of people on anticoagulants and you like can't figure out why in the chart, and it's like, oh, it's probably, you know, because of the clot problem. So yeah, this is as simple as I can make it with this complicated issue here. All right, let's see what time it is. How about we stop here so we can save some for next time. We don't have a quiz, like I said, but if you want me to go back to anything that we talked about today, or if you have any questions, let's just take the last part of class for that. Because I know that at some point your brain's just going to not be able to absorb any more information. So I'm just going to stop here. Anybody want me to scroll back on anything, clarify something, any questions about anything?
You want us to turn these notes in?
Yeah, you can still turn the notes in from today.
I want to go back to that distended artery.
The JVD, let's go back there.
So,
Hold on.
bust,
Hold on.
that just looks terrible. I saw that last night, I was looking at that, I
Yeah.
thought, I didn't read about it, just like going through it, and I thought maybe that was like something in there, like a stent or something, but you actually said that.
Yeah, no, it's just filling up with extra blood and fluid. I don't actually know. I would imagine it could rupture. I don't know if I've ever heard about it happening, but I assume it surely can. Because, you know, aneurysms, we haven't gotten to that, but we'll talk about that in this chapter. Aneurysms is basically just a ruptured vessel from sustained pressure. So I would imagine it probably sure can, which would not be good.
Does that
So
hurt?
when they do that, they not taking blood out of that, they not doing nothing with that, they just letting it be there.
Well, generally,
Let's take a picture.
I know.
remember that this is a symptom of something, right? This isn't like in isolation. This is happening because there's a heart issue, right? They're not like, oh my gosh, this random vein is just swollen for no reason. So they're not going to necessarily treat this. They're going to treat the core issue, right? So the core issue is the heart not pumping right. So they're probably going to give this person a bunch of diuretics to get rid of that fluid, right? And other things. But yeah. It probably could rupture if it stays that way for long enough and eventually just.
I would think it would hurt.
It probably does. I mean,
Bolt it down.
yeah, I've never had one, so I can't tell you.
I wouldn't wanna move, I'd be afraid it would just rupture.
Yeah.
So I'm like,
Yeah.
all of that.
Good question. Anything else want me to scroll back to or clarify? I just want to make sure you guys get the time for this one because this is a heavy chapter. So. Can just scroll back up to the top and work our way down. Was there any questions about blood pressure?
What was the middle one again?
This?
Yeah.
This is where they do it at home. Because some people get nervous in the office, right? And so their blood pressure looks high when it's fine, so they'll have you take your blood pressure at home and record it. I don't know why they call it ambulatory monitoring. Ambulatory means walking. I don't know. I think it's just like, oh, as you go about your life, check it. It's just kind of what they call it. So like you would buy they provide you with a blood pressure cuff and be like, hey, take it 3 times a day, write them down, come back in a week and let us know what your results are, and then they'll see how they look consistently. What about EKG? Any questions about this one?
So I'm still stuck on the neck though.
Remember, this just measures the electrical activity of the heart, right? It doesn't tell you anything about the structures, just what's happening. This would be a good way to tell, like, if the SA node is weird or, like, you know, if there's any arrhythmias. EKGs are great for diagnosing arrhythmias, right? But you have to be having that arrhythmia while you're doing the EKG, right? That's why they'll often send people home with a Holter monitor so that they can catch it if it doesn't happen in that specific moment, right? Because it's not like you're always in an arrhythmia, it might come and go. About echocardiogram, any questions about that one?
The cardioangiogram or the heart cath, does it have to go through the groin?
It can go through the wrist.
Go
Okay.
to the wrist.
Okay.
It just want to go through some vessel that's going to get to the heart.
Okay.
Actually, they're starting to use the wrist more than the groin.
It's, well, is it closer? I guess, I don't know if it's closer or not. It's about the same distance.
Yeah.
But, and remember, there's two different ways of doing an echo. What were the two different ways? T.
T and the ultrasound.
Yeah, so TEE is transesophageal. Trans meaning in this case going through, like transportation is how you go through somewhere. Transesophageal or transthoracic. Thoracic just means this, your chest, right? So this is transesophageal. Any question about the stress test? And again, this is really useful for seeing how your heart responds under stress. So like angina is a great one.
Stress test is for blood clots, to see blood clots, right?
That's a D-dimer test will tell you that. Stress test is just how is your heart responding. Yeah, they'll look and see like if your heart like is unable to cope with the stress. So like blockages could be a reason why your heart is not being able to function well, or you could have valve issues. It doesn't tell you why, and it just tells you whether or not your heart is able to respond to the stress appropriately. So they'll do an EKG like continuous and checking your blood pressure continuously while you're walking on a treadmill, and they slowly increase the pace to see like, is your heart responding well, or are you getting chest pain and having hypoxia when you're doing
That's
this?
why I keep telling them that's what I need, but
A stress test?
they just did an echo and.
Well, you could do one yourself. I mean, you're not going to be able to do an EKG, but you could, take your blood pressure and look at your oxygen and heart rate on that little thing as you walk on a
I actually
treadmill.
have an EKG on my blood pressure machine.
Oh, well, there you go.
Yeah, it's pretty neat.
And again, that angiography is looking inside the vessel to see what's going on through dye, right? They insert that catheter, squirt dye in the so they can see and look at all the blood vessels. And if they can see there's like part of the blood vessel like pinches off, they're like, oh, well, there's a blockage there, right? They can see that. These were the blood tests. Were there any questions about any of these blood tests? Angina.
What did BNP mean again?
I mean, I didn't expect you to know what it stood for. It's, what is it? Something natriuretic peptide, basal?
Oh my god.
He wants to know what BNP stood for. I'm trying to remember.
Oh, yeah.
Is it basal natriuretic peptide?
Yeah.
I don't write all the whole thing down because I don't expect you to know that. I don't even remember half the time what the acronyms stand for, because they'll usually use the shorthand. They're not going to write out the whole thing usually in a chart. So I don't expect you to know what all these stand for, because you probably won't see it that way. Let's see. Angina. What medicine is useful for relieving chest pain? Nitroglycerin.
Aspirin, baby aspirin.
I didn't talk about aspirin, but yes. Mostly nitro under the tongue, right? Heart attack. Yep. I also didn't get into that either. So you can take up to 3, and then after 3, go to the.
We're already, the 911 is already on the way, we
Yeah,
get it.
yeah.
So we already called.
You don't need to know that. She's just don't.
They probably got a huge headache.
Yep.
Yep.
What's this called? On an EKG,
ST elevation.
ST elevation, which is indicative of what?
Heart attack.
Heart attack.
STEMI.
This is an angioplasty with stent. Okay. What number is considered hypertension? Above what?
140 and 90.
A 140 over 90. Good. Congestive heart failure. What test measures how much blood heart pumps out in 1 beat?
Injection.
Ejection fraction. So it's how much your heart is ejecting,
Yeah.
right? That means going out. So what percent? What's the normal number? 55, right? 55 and above, great. Below that, bad. Let's see. What's this called? Jugular vein distension. So distension means it's like distended, right, bigger, and that is the jugular vein. You got your jugular vein and your carotid kind of right in the same place. Carotid is an artery, jugular vein is a vein. So when you feel your pulse, you're feeling your carotid, because pulses are on arteries, right?
Makes me want to just go touch it. I'm weird, like, let me touch that.
What's this called? Right, but the growth here,
Enlarged.
left, this is left ventricular hypertrophy, right? It's the left side, even though it looks like the right, it's the patient's left. Ventricular, because it's the ventricle. Hypertrophy means growing. Hyper meaning too much, troph meaning growth, so too much growth. I don't know what happened here, sorry. All right. Which came first, lung issues or heart issues with core pulmonale? Right, you should get that from the name. Okay, that should be a freebie. Pericarditis is swelling of what? The sac, which is the pericardium around the heart. Okay. I don't know what to ask about this. Who's that? What kind of behaviors put you at risk for endocarditis? IV drug users, and what other, which part of your body? Poor dental hygiene, right? So those are risk factors for that.
Cauliflower.
I didn't write that down in PowerPoint. I don't expect you to know that. It's just what we call it in the medical field, like cauliflower growths. But yeah, those vegetative growths can be from endocarditis, but also show up in what other disease? Starts with an R. Rheumatic heart. Yeah. So that was the one where you had strep, and for whatever reason your body didn't appreciate that, so now it's attacking you. I don't know. So those can show up on the valves as well. Mitral stenosis is hardening of what? The mitral or bicuspid valve. Remember that has two names. Let's see. I think this is towards the end here. All right, which rhythm causes the clot issue? AFib, atrial fibrillation. Which two were the life-threatening ones? Ventricular fibrillation and ventricular tachycardia. So VFib or VTAC. Those, are bad. Which type of arrhythmia requires a pacemaker? Heart blocks, generally. That's just because your heart doesn't know what it's doing.
Third degree.
Yeah, but I don't need you to. There's so many subtypes of heart blocks. We're not going to get into that.
On the bridge.
Yeah, Winky Bach, Mobitz type 1, Mobitz 2. You don't need to know all that. It's too much. I heard this. I saw this YouTube video. You know that I'm bringing sexy back, but it's like I'm bringing Winky back. I think it was probably like a project they had to do for school, but it was so funny. All right, well that's pretty much where we left off. We'll pick up with vessel issues next class. As you review, please send me emails with questions. Right, I welcome questions. And again, we'll pick up with this next time, and then we'll have our quiz next class. Okay, still turn in your notes from today, right? And then you'll just turn in the second half of your notes next time. Sound good?
Besides,